Welcome everyone to tonight's Woo You presentation. I am your host, Dr. Jennifer Stewart. So it is my great pleasure. I feel like I have this memorized. It is my great pleasure to introduce Dr. Selena McGee. She's the founder and owner of Bespoke Vision, a boutique practice that offers patients a wide range of optometric care through dry eye, specialty contact lenses, and aesthetics. She's the first OD in the country to perform neurotoxin injections and laser resurfacing. She performs RF, IPL, and surgical lid procedures. She's a renowned national and international speaker and a very popular and well-attended Woo You presenter. She's an adjunct assistant professor at the Northeastern State University College of Optometry, currently serves as president for the Intrepid Eye Society, trustee on the SECO board and the Board of Examiners in Oklahoma. She's a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and is past president of the Oklahoma Association of Optometric Physicians. I think I got it all. So Dr. McGee, welcome. And this is going to be awesome. Again, make sure you ask those questions in the chat and the Q&A, and we'll get to that at the end. And with that, I'll turn it over to you, Dr. McGee.
Awesome. Thank you. So one of the first questions already in the chat is handouts. So I didn't send slides to you guys, but I did send an article that we published a couple of months ago just around neuroadaptation and presbyopia, which we'll talk about tonight too, but it was a little bit of a teaser. So I did things a little bit differently, but here's my financial disclosures. Everything's been mitigated throughout this course, but we're going to talk about something that you and I do and ask our patients to do every day, but we're going to think about this in a different way. And this really took my interest over the last 18 months because of new things coming in presbyopia. But neuroadaptation is something that we all talk about, expect our patients to be able to do, but we don't always vocalize that. And so whether it's a contact lens, whether it's a spectacle, whether it's an IOL, and with all the technology that has changed in that piece, I thought it was a really good time to talk about this because I've changed the way that I talk to patients and it's made a really big impact. And so I wanted to share some of those pearls with you guys, but I also want to hear from you all because this is a new topic for me to talk about. And one of the big reasons that I'm talking about it is because patients are frustrated between the different modalities. And we've all had those multifocal contact lens patients that are, saying to us, just can't you make it like a little sharper here or a little sharper here? Or why can't I just put my contacts in and be able to see? Or they've spent a very large investment on an IOL and now they're really unhappy. You have that, we talk a lot about the 2020 happy patient, but we have plenty of 2020 unhappy patients. And, what do we do in those moments when we have those patients? And are there conversations that we can have before we get to whatever choice that we're going to make for the patient or have them help us make that helps us with these conversations? And patients don't understand sometimes why they can't just see. Can't you just make this happen, Dr. McGee? Like, just fix it for me. And it's not always that simple. And the visual system and the eyes and everything that go with it, it's the second most complex organ behind the brain. And most of our patients don't know that, and they don't know what they don't know. And it takes a lot of chair time. So I'm curious, what you guys have experienced as far as neuroadaptation, or what does that term even mean to you? So I would love to just hear from you guys just for a moment. You can put it in the chat or the Q&A. Just curious what you think about when you say neuroadaptation. So type that out and I'll keep moving forward. But I want to definitely make this interactive. But what I have started taking to the lane and the way that I express to patients is when we do anything, whether it's even a new spectacle RX or a new contact lens prescription that doesn't involve presbyopia, we're asking our brain to do something different. And it's a different image. It's a different image size. It can be two images at once if we're doing something with a multifocal where we have diffractive optics. So our conversations need to revolve around the brain has to make these adaptations, which it really can do a fantastic job of, and it does it all day, every day, but we're asking it to do something new and different. And I think it really sets expectations up well for you and your patients. It can save a ton of chair time on the back end because now the patient understands, oh, it's not just the technology. It's not just Dr. McGee and what she's giving me. I actually have to let my brain do what it's meant to do. And maybe there's some things I can do to help that. So that's what we're going to talk about tonight. Okay, I'm just going to go through and look. Neuroadaptation involves PRISM, why some patients have significant issues, even with just a quarter diopter of astigmatism. So true. I think of low presbyopic astigmats that want perfect vision, but are only willing to wear the glasses when they think they need it. I mean, all of these, right? I love that you guys are putting in here. Perception adjust based on what is done to our visual systems, and our brains have to make sense of it. And then the brain develops new pathways, new experiences. You guys are all exactly right. So the other thing to know about this is there's not a lot of studies and there's not a lot of information out there about this. So that's the other reason that I wanted to talk about it, because as we raise more awareness, then maybe we can start to think differently, and maybe we can have some clinical trials that, you know, involve an fMRI and looking at pathways and what this means. But there is some literature, but not a ton. So what do we know about neuroadaptation? What does that actually mean? So the brain has this incredible ability to respond to input from the outside world, but it has to filter out everything. Otherwise, we would go crazy because there's so much information coming out. So it has to be able to filter out that noise. And the process of reacting when something is new and different or disturbs our vision, that's what neuroadaptation is. So neuroplasticity is a little bit different. That is the actual process by which the brain can reorganize the structure, the function, the connections, and respond to the stimuli, whether it's noise or whether it's something that we want to intentionally process. And that's how we respond to stimuli, and that's how we neuroadapt to something new and different. So that's how the brain is wired. But there's some things that go into neuroplasticity and what that affects. And aging is a big one. So as we have more birthdays, our ability to form those pathways, and that affects our neuroplasticity, it actually slows down. So that's something to take into consideration when you're talking, especially about different types of implant lenses and being able to set expectations for patients based on when they're having cataract surgery. So, you know, I think those conversations really have to be intentional, but this is another layer to it of why they have to be intentional. And also, maybe we make a case for, should we do surgery sooner than later? Because are they going to have an easier time of adapting because they have a higher ability to develop neuroplasticity where it happens faster? I don't know the answer to that, but I'm curious. And I think that's a really good question and something that we should consider moving forward with all the technology that we have available to us in the surgical suite and helping our patients have their best vision with cataract surgery. And we'll talk more about that. But just to review, and again, I'm keeping this interactive because when you start talking about optics and lower and higher order aberrations, and it's in the evening, we've all had long days of work. I want to keep everybody and make sure we stay awake. So just as a review, lower order aberrations are the things that you and I correct every day: myopia, hyperopia, astigmatism. Higher order aberrations are what happens with coma, trifoil, spherical aberrations. And I've got some good examples just picture-wise, and I use that point spread function frequently in the exam lane. I have an OPD3 that allows me to show that point spread function to patients because they don't understand these higher order aberrations. They've never even heard of that term. They just think that with their new pair of glasses or their contact lens, that everything should be pinpoint perfect. But when you have that point spread function that shows, even with the best correction possible with the technology we have, they're still going to have, if they have coma, if they have spherical aberrations, they're still going to have that. And so having that point spread function and showing that image to them can be really powerful in the lane so that they understand, oh, this is what technology we have today is capable of correcting. We don't have technology yet to correct these things because it can be really hard to explain. So I rely pretty heavily on my technology in the office to help me with pictures and images very similar to these on point spread function and the retinal imaging. How much is too much? Normally, the retinal image quality due to higher order aberrations goes unnoticed. It's part of that noise. The brain neuroadapts to it. It doesn't really notice it. But when you change it or you go beyond 7%, it's really bothersome to patients. And that, of course, is also going to vary from patient to patient, but it gets on overload and it's just stimulating. They can't really turn it off. So just knowing that, and we'll talk about neuroadaptation with implant lenses, but that's when things change overnight. Or if you have laser surgery with LASIK or monovision LASIK, that happens, really quickly. And so things change and there's going to be a gap there where the brain has to be able to interpret those visual images in a new way with the same brain. So what other factors play a role in this? Tear film is mission critical, and you guys all know me. I am super passionate about dry eye disease and the ocular surface because it affects everything that you and I do, and it greatly affects patients' quality of life, and it absolutely affects all of what we're talking about, whether it's spectacles, contact lenses, implant lenses. That tear film and that first interaction from the air, that has to be stable, because when we don't have stable tear film, now we have scatter, we have more higher order aberrations, and we complicate the picture. Irregular corneas, like as an example, is keratoconus, that plays a role. Pupil size absolutely plays a role. Our best visual acuity is going to happen between 2 and 5 millimeters. Below 1.8, you're going to start getting degradation because you're going to get diffractive changes. Above 5 millimeters, you're going to have degradation due to spherical aberrations, which is why patients sometimes struggle driving at night. It's different when they're in a brightly lit room and they're by a window and they're like, oh, I don't even need my reading glasses when I'm here, because pupil shrinks, we get depth of focus, right? So that relationship also between the cornea and the lens can change higher order aberrations, as well as lenticular changes as they get cataracts, as things change there. Those all play into a patient's visual system and how they perceive and how they see. And then the axial length of the eye also plays a role. So, of course, and we're not going to talk about this, but we all know, and are many, over 600 different published studies last time I looked on axial length with myopia in children. And we all are doing more and more research around that and talking to our patients about that and helping to slow down myopia through slowing down axial length. But that absolutely is critical to a patient's visual system as well. So looking at how do we apply and take all of that clinically, we have to make sure that patients are screened and treated for dry eye disease. Ocular surface optimization is the beginning of this. And that every patient deserves to have that that's sitting in our chair. And it doesn't have to take a long time. It can be super simple. A questionnaire, like a speed questionnaire, looking at tear film with vital dye and looking at the corneal epithelium, and then just pushing on glands. Those three things, you can absolutely screen patients and diagnose and treat those patients for dry eye disease. That's step one. But we also have to teach patients that their visual system has to undergo these neuroadaptation changes, and that timeline varies from person to person. And it's going to vary from age. It's also just going to sometimes depend on their personality and what they can turn off and turn on. And then the last thing is we have to establish what success looks like. And we need to do that for the patient. We have to fully understand what they're trying to accomplish with their vision. If we don't know what their expectations are, and I have a really fun study further in the lecture here that looks like what they want. And sometimes we can meet those things, but sometimes it takes more than one way to meet those things. We have amazing technology, but it typically, in my experience, is going to be more than one modality. It's really rare that we're going to be able to help a patient with one pair of spectacle lenses, one contact lens, one IOL, one therapeutic drop, all the things. It's rare that you're going to have a person that has perfect vision with just one modality. But the good news is we have all of this technology that we can establish that, and we can establish what success looks like for our practice. And we're going to establish what success looks like for the patient. But we have to talk about that before we get into all the options. Or I promise you, and you've experienced this, I know I have, then I start spinning my wheels and now we're backpedaling and I'm trying to explain things. The patient's frustrated, I get frustrated. So just changing how we talk about this has been really helpful in my practice. So let's start off with spectacles. It's easier with smaller powers. So I will definitely start patients. Let's just talk about presbyopia for a second, because with spectacles, they're starting off with a low ad. It's not a good idea to wait until the patient needs a +2 ad to put them in a progressive ad lens. That's a much harder lift. So we baby step. And I tell patients that let's start with a boost lens when you're 39, 40, 41. And then we'll slowly build, because it's so much easier for you to adapt to that when we have smaller powers. Typically, it's going to take 10 to 14 days. And that's what you and I have talked about, at least I've been practicing for 21 years. And that's what I've always said to patients. Give yourself 14 days to get used to this. Try to wear it every day. It's less helpful for you to wear your old glasses and then try on the new ones for a few minutes and then immediately go back to your old ones. We have to wear those new ones so that we can help build those pathways and limit switching back and forth from habitual to new. And when you explain it like that, it feels, at least in my experience, less like we're asking them to do something really hard. It's like, oh, there's an actual reason for why we're asking you to do this for 14 days. And this is what we find works best. So that's what we have with spectacles. And that's how I talk about it. Do you guys have any, I'd love to hear, is there any other pearls, things that you talk about? I had a patient today while you guys are typing in, and I'll answer there's a couple of questions that I'll answer too. But I had a patient today that was really struggling in her distance, and she's a high myope, and she's also got 9 diopters of prism in her prescription. And we looked at the exact layout of her lens. That was good, but she was in Trivex, and then her old lenses were a different material. So the Abe value is different, which feels different. And so for her, we had to match everything. And that's super critical too. Sometimes it's actually the lens material that makes a difference. So I love somebody that put in a trial frame. Absolutely. That's very helpful. One of the questions is, what is an OPD3? So that is a specific type of topography that also measures spherical aberrations, and it measures pupil size in mesopic and photopic conditions for me. And then it allows me to have that point spread function. So it's my topographer that I've got in my clinic. So let's talk about contact lenses and some just pearls here. Let the patient wear the prescription. Limit that in-office change to less than 2. And what I'm talking about specifically here is presbyopic prescriptions. Even if you have somebody that's a high myope and you change things a little bit, or a hyperopic patient, that's going to take a little longer. So this really does apply to all prescriptions, but let the patient actually wear it in their world and limit those in-office changes to less than 2. If we're talking about presbyopia, the center near designs do take longer for the brain to adapt, because remember, you've got two images happening on the retina. And so the brain has to figure out which one it's looking at for what. And I'm now at the birthday that I'm in a multifocal contact lens. And it's interesting when I am, for example, walking through an airport, it will take me a little bit and I can now see all the signs. But if I sit and, work on my laptop or read my phone for a bit, this all becomes very clear. And then when I get up to go, walk to my gate or wherever I'm going, things at distance are blurry. And it takes a minute, sometimes 5 minutes, for my brain to figure out what I'm supposed to be looking at and for that to become clear again. So it just takes time. But the larger the anisotropia, the longer it takes. We've learned that with monovision. That's not a big surprise to any of us. And it can take, maybe a week, but sometimes it takes a few months for patients too, depending on the contact lens design. And it's because the brain has to see those simultaneous images, unless you're doing like a translating type design where you've got, definite demarcations and you don't have simultaneous vision happening. But we always thought that this happened only in the visual cortex, but there was a study that they were looking at. It actually may start in the retina based on a multifocal ERG, and I've got the study listed there if you're curious about learning more. So sight dominance is super important, as well as sensory dominance. So I was always taught to do sight dominance years ago, but I've shifted that, as many of you probably already have. And if you've, graduated in the last 15 years, you're probably doing sensory dominance. And I have found this much more helpful and much more accurate on which eye is dominant. And so I just use a +150 trial lens. You can also do a +150, in the phoropter. Your retinoscopy lens works great. Which do you feel like disturbs your vision the least? And that way you have sensory dominance documented, and it definitely helps with monovision patients, multifocal lens patients, whether it's contact lens, certainly whether it's IOL. But that's a big piece to this that's really simple and a great tip, using sensory dominance over sight dominance, because it is more accurate. So let's talk about pupil size. What happens to pupil size as you have more birthdays? It gets smaller, right? And of course, this is just a rendering of pupil size. And no, she doesn't have Horner. She doesn't have a third nerve, but I did it just for the sake of looking at it. But as we have more birthdays, they get smaller. And it's interesting when you look at contact lens designs, they will typically stop on the add power around a +150, a +2. And then it's like, well, wait, what about patients that need a 250 or a high add? What happens there? Well, as we have more birthdays and those patients that need a 250, their pupil gets smaller. So they get this extended depth of focus along with the plus power. So there's some interesting things that happen with contact lens design that is way above my pay grade and way above my sophistication level. But what we do need to know is that pupil sizes do change, and they do change as we have more birthdays. And we're going to talk pretty specifically around pupils when we get to talking about therapeutics that are intentionally changing pupil size. And then also when we talk about IOL'S. So when we're talking about contact lenses, it's always a good idea too, to be able to demonstrate to patients what success looks like, because when they're in a monofocal distance lens, great, that looks good. But let's take near, they can't read anything. But when you have a multifocal contact lens on, notice what happens with that distance. There's just a little bit of less crisp with that. Now you can still read at distance, and you can absolutely still read up close. And so you get the best of both worlds. But if patients expect to be able to see distance like monofocal lenses have the ability to, and they expect to be able to read like a monofocal lens does, say with a reading glass prescription, or if it's a myope like myself, well, just make it like when I take my contact lenses out, doc. Why can't you just do that, right? How many times have you guys heard that? And so this is important, because this is success. This is successful. This person can read at distance, and they can also read up close. But if they don't understand that, this is going to be an epic failure for them. So super important on how we talk about this. And remember, patients are always going to compare whatever technology that you are working with them with, they're going to compare it to their reading glasses. And again, I'm specifically talking about presbyopia here, but they're always going to compare it to that. They want things to be bigger and they want it to be clearer. The only thing that does that is reading glasses. There's nothing else that does that. Our IOL'S don't do that. Therapeutic drops don't do that. So we have to have this conversation and talk to patients differently about what to expect. And just for fun, I have no idea what language this is in, but it's definitely not English. So anyway, just a little sidebar there, making sure you guys are paying attention. So 18 months ago, we had a drop that came to market specifically for presbyopia, the first in class. Now we have a therapeutic miotic drop for presbyopia. And this is looking at how do we talk to patients about it? How does this actually work? And what do we think about pupil size? Like we've been talking about, as we have more birthdays, pupils get smaller. So the way that I explain this to patients is when you're standing next to a brightly lit window and you notice that you may not be as dependent on your reading glasses. Have you noticed that? And they're like, yeah, sometimes I don't even need them. It's great. Make that happen. I can do that with a drop. And when you look at, okay, how do I choose patients or how do I incorporate this into my clinic? What I have found has worked best for me is measuring their near uncorrected acuity, which I never did historically. So when I refract, I, of course, do their distance refraction. And then as I bring the near card down at the phoropter, I would always just get ready for the add power. I would turn the little light on. I would start pushing plus and then ask the patient to start to read. But I pause now and take just a moment for the patient, when that near card comes down, before you turn the light on, just use the normal ambient room light. And before you put any plus in, just ask them what they can read. Because now when you know what their uncorrected near acuity is, now you can set expectations. Because what we know about the current drop that we have that's available, we can add 3 lines, which is about a plus 150 add. And I know their pupil size because I've looked at that with my technology. Best candidates are going to be emmetropic presbyopes or low hyperopes that need that 150 add. Now, can you use it outside of that? Absolutely. I've had patients wildly successful outside of that, but this is a great place to start. And it gives you an opportunity to know how to set the expectations up for patients. Just that one measurement of measuring near uncorrected acuity, I think is super important. And so that's why I have this picture up, clear, not clear. Another pearl that I learned from one of my colleagues, and I haven't done this, but I think it's a really interesting idea. When you hand a near point card to a patient and the lowest point is 20/20, right? Which is tiny font. And that's what's functional vision, 20/40 up close. So this clever doctor just clipped off everything below 20/40 because patients would look at it and they're like, well, yeah, I can see 20/40, but I want to see the rest of this card. Why can't you make me see like that? Make me see like that, Dr. McGee. And so he just cleverly cut it off because 20/40 is perfectly functional. And that was the endpoint that he wanted to set. And so he defined success for his patients by doing that. And so sometimes it takes things like that and thinking a little bit differently outside the box of how to set patients up for success and how to define success for them. But I thought that was an interesting way to do that. So remember that when we reduce pupil size, we extend that depth of focus. And so as we have more birthdays and the pupil size gets smaller, like we were talking about with contact lens designs, that can help us. When we have a therapeutic drop that extends the depth of focus by making our pupils smaller, there's some things here that we need to tell patients. And this is one of the biggest learnings that I have come across in the last 18 months having a drop available. I mean, none of us knew any of this before 18 months because we've never had anything like this. So magnification and clarification happens with reading glasses. So you get a magnified image, right? It gets bigger and it's clearer. When you have a constricted pupil and you have depth of focus, you have clarification, but it's not bigger. Now, with reading glasses, what's the narrow part of that and what does it not do? We have this really narrow depth of focus. It has a focal point, right? The +3 is at 33 centimeters. A +2.5 is at 40 centimeters. All of those pieces, they have a very specific focal point. So that's why you see people running around with a pair of reading glasses here, another one on the end of their nose, and a different one tucked into their shirt because they're all different powers, right? There's a better way. And so that's the challenge with reading glasses. But if we don't do a good job of talking about the fact that with depth of focus, you have clarification, but not magnification. And remember, what are patients going to do with anything that we talk about? They want magnification. They want it to look like their reading glass prescription, and it's not going to. So that's been super important for my conversations when I talk to patients about having that extended depth of focus and having that capability of moving along that depth of focus, but just having clearer images, not necessarily bigger images. So hopefully that makes sense. The other thing that's really key that I've learned, and now we have data to support it, is do patients have to neuroadapt to a drop? They have to neuroadapt with contact lenses. They have to do it with spectacles. They have to do it with implant lenses. What about a drop? Well, as it turns out, they have to. And when you look at this data, we're looking at Vuity and we're looking at a 3-line gain, and patients get better the first 14 days. And then it starts to kind of plateau, which was always interesting to me because that's what I told spectacle wearers too. And so this data to me is interesting. And this is why I have changed how I prescribe therapeutic drops. I used to drop people in the chair, but now I have patients utilize it every day for the first 14 days. So this is the data that's been published that we have seen, and we've got Gemini 1 and Gemini 2, and then Virgo data with this drop. And we see the same thing happen with Virgo, which is patients were utilizing it twice a day instead of just once. But we saw the same kind of pattern, day 1, day 7, day 14, they continue to get better. So is there some sort of neuroadaptation that takes place? Looking at this data, I think there is. And so that's how I talk to patients about it differently than what I did 18 months ago. So we've talked about spectacle lenses, 14 days. Contact lenses can be 7 to 14 days. It can also be like 8 to 12 weeks. What about our surgical patients? You know, and with spectacles, contact lenses, therapeutic drops, those are all reversible, right? If a patient doesn't adapt to their spectacles, we can change it. If they don't adapt to their contact lenses, we can take them out. If they don't adapt to their therapeutic drop, they can stop taking them. But surgical patients, very different, right? This is not something that you easily fix. So a careful history is paramount. We have to rule out significant ocular pathology, including ocular surface disease. Screen out patients with high expectations. Type A personalities run, or just have very good discussions. Young with great pre-op visual acuities and large pupil size. Those are all risk factors for slower neuroadaptation or never neuroadaptation with cataract surgery. So considerations, make sure you do a careful history, right? And here's the thing. You and I are the ones that have the relationships with these patients. We understand their personalities. We have fit them in contact lenses. We know how many contact lenses we had to go through to get them happy. We know how many spec RX checks we've done. We know this. Our surgeons do not. Many times our surgeons meet them on one visit, and they have to quickly assess a patient's entire personality and their entire history in a 7 to 10 minute exam. That's asking a lot. So we can really help our surgical counterparts by giving them all of this information. And so I am very specific when I send patients for CAD evals. Here is what we have talked about. Here is what I want the patient to have. etc. Like I'm very specific and I'm not afraid to say what technology I want the patient in. And I give them the reasons. And I have really good relationships with my surgeons and they understand why. We have conversations around that all the time. But contrast sensitivity is super helpful. Of course, a really good refraction. OCT of macula is mission critical because sometimes you'll have subtle epiretinal membranes that you can't see behind the slit lamp with your fundus biomicroscopy, and that will ruin the best of the technology with an implant lens set for helping a patient with their intermediate vision and reading. So we don't want to make that mistake. Topography, very helpful. Pupillometry, and do they have an angle kappa that is just off? That's going to play a role because you want to have these center designs and you need that to all line up throughout their entire visual system front to back. It can actually take patients around 6 to 12 months to neuroadapt. 10% of patients will never neuroadapt. So those are conversations that we need to have with our patients. Listen, you have cataracts. I'm referring you for a CAT eval and cataract surgery. This process and the way that your vision is, it is going to take us a full year from now till a year from now for your whole system and your brain to understand how it's seeing differently and for you to have the best recipe for success. When I tell patients that, you can see their eyes kind of get like really big or like, what, a whole year? But it absolutely is so much better to have that conversation on the front end than 6 weeks after when they're miserable. And we'll talk more about that, but tell patients that on the front end. They can experience any of the following: photopic phenomena. We're going to talk about dysphotopsias: blurry, waxy vision, insufficient vision, monocular diplopia, shadows, halos, and glare, which is part of dysphotopsias, residual ametropia, reduced contrast sensitivity, and posterior capsular opacification. All of those things can happen with the best of intentions, the best surgeon, the best technology. These things can happen. So if you're in a position that a patient has had an implant lens and they are struggling with their neuroadaptation, just make sure that you don't do a YAG. If there's any consideration that we might have to explant that lens, which is a last resort, you just make sure they don't have a YAG. So there's different designs and they split light and foci differently. Monofocal IOL'S are great for distance, right? Enhanced range IOL'S give us good distance, good intermediate. Extended depth of focus takes it a little bit further. We get some near. Multifocal IOL'S work great at distance, great at near. And then trifocal IOL'S give us distance, trifocal, intermediate, and near. And there's some little gaps in there. So what happens with this? So let's talk about dysphotopsias first. A dysphotopsia happens when you have light coming in that's off axis. So positive photopsia is the presence of extra light. So that's the glare, the halos, the starbursts that patients can have. Negative photopsia is the absence of light. So you'll have patients that come in, they're like, man, I have this weird dark arc over here that I see all the time. It's driving me crazy. Or I see it in bright light, but it seems to disappear in dim light. And they'll describe it as this dark moon-like arc. That's a negative photopsia. So those things will get better over time. The brain has to see it as noise and it starts to turn it off. And again, it's going to vary how long that takes from person to person, how many birthdays they have, the type of technology they have. Did they have any kind of ocular surface issue that wasn't addressed? Glare and flare, halos, starbursts. And by the way, patients are entitled to have more than one dysphotopsia. So sometimes they have all of them, or they have them in combination, right? So these are all things that our patients can experience with multifocal and extended depth of focus IOLs. We have amazing technology, and now we have light adjustable lenses where we can tweak things. And for those patients that really want and need things really dialed in, that's what I'm going towards. Sorry, my throat's like super dry. Because as the name implies, light adjustable means we can adjust it. We're not locked into one power. We can let that settle for 3 weeks, and then we go back and we can change things. If they have to that, the doctor that said, what about the person that needs a -1/4? That's the difference of, for that patient, being miserable or being ecstatic or at least happy. And you can tweak that by 1/4 when you have a light adjustable lens. I use them often with patients that are post-refractive because it can be a challenge to get really good IOL calculations on those patients. And so with a light adjustable lens, we can make that happen. And there's lots of technology out there. There's lots more coming in the pipeline with the modular multi-components. And, also, can we femto sculpt a light adjustable lens? The interesting thing about light adjustable lenses is they are monofocal. So you're not splitting light, but the way that the backside of that lens bends light, you actually get really good near vision. And so we'll do a modified monovision, and you can mitigate some of those dysphotopsias because you're not splitting light, and still get patients to read really well. So definitely something to look into if you guys aren't utilizing that technology with your surgeons. And then, of course, there's lots of things in the pipeline for accommodative lenses and then lens refilling technology. So certainly this is becoming more and more commonplace, and patients expect to have great vision after cataract surgery because their neighbor did, their friend did, their aunt did, their mom did. They want this to be, it's a refractive procedure. And so you and I are in the driver's seat with these patients, and we really can help our surgical partners by walking through this with our patients, getting all of the good history, setting patient expectations, and having these conversations. So indications, of course, presbyopia, refractive lens exchange, patients that are lost most of their accommodation are great candidates. Of course, cataracts, and then negative patient factors. If they have any kind of ocular pathology, high expectations, unrealistic expectations, younger patients that have perfect distance vision, that's a hard patient, larger pupil size, type A personality. We walked through, we need all that information pre-op. And then we talked about the adverse events. But my surgeon and I always had this conversation that if we talk about it before surgery, it's an explanation. We talk about it after surgery, it's an excuse. And those conversations do not go well. And so we really try to make sure we do everything on the front end to talk to patients about this. What's the single most important factor for success, no matter what kind of modality we're choosing for patients, specifically around spectacles, contact lenses, therapeutic drops, implantable lenses? We have to measure the criteria of what the technology can do, and then we match that to the patient. And I will tell patients, I don't want you married to the wrong technology for the rest of your life. So this is why I'm asking these questions. I want to make sure that we get you the right technology that matches what you want to be able to do day to day, to enjoy what you do day to day. So that measuring criteria is super important in managing expectations. So here's that study that I was talking about earlier. When you look at what patients expect, that's a big ask, okay? Like most of them say, I want to see clearly in all situations. I don't want to have to wear glasses. I want freedom from the worrying of forgetting my glasses. I don't want to have to switch between multiple pairs of glasses for different activities. I want reduced dependency on glasses or contact lenses. I want increased freedom to participate in sports, and I don't want to have to change my glasses every couple of years. Now, are we going to be able to meet all those? Absolutely not. But the patients don't know what they don't know. We're not just changing their glasses every couple of years because we want to. We're doing that to give them the best vision possible. And as you have more birthdays, things change. Seeing clearly in all situations is something that only happens for the first half of our life. And sometimes not even then. I've been wearing glasses since I was 10. So I have a little bit lower tolerance sometimes because I have always struggled to see well, and it's just part of who I am. But I have to remember that for some of these patients, they've always seen well, and how incredibly frustrating it is for them to not have that capability anymore. But with the technology, we can help them, but we can't do it if they expect, I don't want you to change my glasses ever, or I don't want to have to switch between multiple pairs of things to do different activities. So that's when you can bring to life maybe if you're talking to a guy, it can be a tool like, are you going to change out an outlet with a Phillips screwdriver trying to unscrew the screw with a flathead? No, I mean, you can, but it's super awkward and not the right tool. You need multiple tools. Or if I'm talking to somebody else and I have on tennis shoes right now, am I going to go like for my 5K run and my high heels? Absolutely not. I'm going to do it with my tennis shoes. So asking people to just think differently about how they want to see and getting those expectations out on the front end and what success looks like can save a ton of chair time, because there is a disconnect in what patients expect and what we could prescribe. We have to be completely transparent about expectations. We have to remember patients don't know what they don't know. The more time we spend up front with the patient, the less chair time later. And remember, before a problem arises, it's an explanation. Any discussion after is an excuse. And then, are you holding yourself and your patients back from amazing technology because of expectations? Maybe some of the expectations are actually some things that you've experienced and you stubbed your toe. I have stubbed my toe. I got burned on this technology and I was like, oh, I'm never doing that again. Like, cross my arms and say this. But if I go back and reverse engineer it and look at, okay, what did I miss? And okay, well, if I had asked this question, or if I dug a little deeper, I would have uncovered that. Or if I had said this in this way, the patient would have understood. So I think sometimes it's important for us to get out of our own way. I have done that to myself lots of times. And I love this picture, 6 versus 9, depending on which way you're looking, depending on what you're expecting. So just a good example. And then we cannot forget, and this is Milton Haum's quote, we absolutely cannot forget the X factor. Patient motivation is everything. They will make anything work if they're highly motivated, whether it's spectacles, whether it's contact lenses, whether it's a therapeutic drop, whether it's a multifocal IOL or an extended depth of focus IOL. The X factor is patient motivation. If you understand patient motivation and they are motivated, you can knock it out of the park. But that part is key. So setting expectations, this is what we're not going to do after this lecture. We're not going to cross our fingers, close our eyes, hold our breath and go, oh, please let this patient like this implant lens that we just did. We're going to choose our patients wisely. We're going to understand their personalities. We're going to share that with our surgeons. We're going to do a lifestyle questionnaire and really understand how the patient wants to be able to use their vision. What do they want to accomplish with and without spectacles, with and without contact lenses? We're going to talk to patients about what to expect with neuroadaptation, and that their same brain has to see these new images and be able to interpret that and turn off some of the noise. For spectacles, 14 days. For contact lenses, 2 weeks to months. Therapeutic drops, based on the information we now know, 14 days. Surgical, 6 to 12 months, and in 10%, they will never neuroadapt. So those are all things that we can talk about on the front end. And then the easy one, we're going to optimize the visual system and their ocular surface.